my name is Sandy Kurtin, and I'm here to talk to you about a guide to transfusions and iron overload. Red blood cell transfusions are very common in MDS. They provide a way to give temporary relief of the symptoms of anemia associated with MDS. Nearly 90% of patients with MDS are treated with red blood cell transfusions at some point during their diagnosis. There are some potential risks associated with red blood cell transfusions. Most of these are mild and easily treated, and there are more details about this in the Building Blocks of Hope booklet. One of the risks of red blood cell transfusions is iron overload. Each unit of packed red blood cells adds roughly 250 milligrams of excess iron. There is no normal mechanism in the body to get rid of extra iron, and after approximately 20 to 40 red blood cell transfusions, you may have accumulated 5 to 10 grams of excess iron. This is reflected in elevated serum ferritin levels, which is a blood test. You can see those levels go to 1,000 or 2,000, where normally they're below 100. You may also see iron in the liver or the heart, and we'll talk about tests for that in a moment. This excess iron can accumulate in these organs and cause what we call end organ damage. In the heart, this may increase the risk of cardiac-related events, myocardial infarction, congestive heart failure, and arrhythmias or abnormal heart rhythms. In the liver, we may see an increased risk of cirrhosis, which is a scarring in the liver, or other signs of hepatic dysfunction and elevated levels of liver enzymes. In the endocrine organs, we may see hypogonadism, so that this is below normal testosterone, for instance, in men, hypothyroidism, or diabetes because of the effect on the endocrine glands. So which patients may benefit most from chelation therapy or treatment of iron overload? This iron overload occurs over a period of time as a result of repeated transfusions. So transfusion status, people who are transfusion dependent, still needing transfusions, we're going to take that into consideration. If you're requiring 2 units of blood a month for greater than 1 year, or have received 20 to 30 units of blood, you're going to be more at risk for iron overload and may benefit from chelation therapy. Then we look at how it's affected your organs, and we do that by testing serum ferritin levels. And there isn't really a consensus worldwide on what that number is that indicates the need for chelation therapy. It ranges somewhere between 1,000 and 2,500. Again, normally the ferritin should be less than 100. If we do see evidence of tissue iron overload with continued transfusion dependence, such as abnormalities in the liver or the heart, that would be another reason to think about chelation therapy. In patients who have lower risk MDS or certain subtypes of MDS, we know that their life expectancy can be many years, and it makes sense to treat the iron overload using chelation therapy. We also consider this for patients who are being considered for a bone marrow transplant. We know that bone marrow transplant patients do better if their iron overload is under control. There are a number of iron chelation therapies currently available to treat iron overload. Each of these has its own side effect profile and route of administration. The first of these is desferal. It is given either intravenously or subcutaneously, and usually has to be administered over several hours, several days a week. The second is Exjade. This is an oral drug that is taken once a day. Feraprox is a drug that's currently available to treat iron overload only for other diseases such as thalassemia or sickle cell disease. It is not currently approved for the treatment of MDS. And the last option is phlebotomy, and this is where you remove units of blood which carries the iron with it. This is an option for some patients who have had their MDS effectively treated and have normal hemoglobin levels. All of these drugs have potential side effects, so let's talk about that. Each of them can have some renal toxicity or toxicity to the kidneys, so it's very important that we monitor how the kidneys are working, and we do this through something called a serum creatinine level, which is measured in your blood. We also may see excess protein in the urine, so you may need to have a urine sample for monitoring of that. It may affect the liver, as we've previously discussed, and we measure this through blood tests and something called transaminase levels. And then lastly is it can have some gastrointestinal side effects. The most common of these are diarrhea and nausea. These can be managed easily using anti-diarrhea medications. Sometimes dose reductions are required. In the case of Exjade, which is an oral drug, taking this later in the day is often beneficial, and there's more information on taking Exjade in the Building Blocks of Hope. Some of the other possible side effects of chelation therapy include pancytopenia. This is a word that defines low blood counts of all cell lines. Neutropenia in particular, low neutrophils, and thrombocytopenia, low platelets, have been reported in patients receiving chelation therapy. So we monitor this closely by checking your blood before we start and at regular intervals while you're on the chelation therapy. Two other rare but potential side effects include auditory and ocular abnormalities. That's basically hearing and vision. So we see in some patients what are called high-frequency hearing losses or decreased hearing in people getting chelation therapy. For this reason, we check your hearing before we start treatment and once a year after you've started. Similarly, for your eyes, we may see increased rates of cataract formation, lens opacities, or increased pressure behind the eye, such as in glaucoma patients, and then rare retinal disorders. Again, we monitor this closely by having an eye exam before we start and at regular intervals. Other things that we'll be checking while you're on chelation therapy are listed here for you. The serum ferritin we talked about. This is the easiest way to measure the level of iron in the blood and tissue. We would do this every 3 months. The liver enzyme studies or serum transaminase levels, generally monthly, as well as the kidney function. There are a couple of ways we look at iron in the liver and in the heart, and these are very special MRI studies. So these are radiology imaging studies, and they are specifically geared to monitoring iron in those tissues. We mentioned the auditory and ophthalmic testing, which is done at baseline, and then once a year, otherwise known as annually. So iron overload can be effectively treated with chelation therapy. It does require monitoring, and we use this in patients where we see the best outcomes and the most benefit.